When we brought pain in for every case when I was in residency, was anytime we did a thoracotomy, it was a non-negotiable.
Yeah.
Pain was consulted before the case, just for people listening. A thoracotomy, we didn't do these often because a lot of times by the time I was in residency, we did minimally invasive surgery in the chest.
Yeah.
But sometimes you had to actually make a huge incision under the ribs, and that's a very painful. We just you just know this from experience that's such a painful experience. You cut this huge incision in the intercostal muscles. You put rib spreaders in. You crank these things open so you can do this big operation. We just know those patients are going to need an epidural catheter, and we want that in before surgery, not after.
Yeah.
And it makes all the difference in the world. So pain was a part of that response. I don't remember us routinely bringing pain in otherwise, but things have changed, I'm sure, in 20 years. So today, for a general abdominal case or a general orthopedic case, are you brought in preoperatively?
Yeah. These days, there's a lot of movement towards these ARS protocols and enhanced recovery after surgery. And so, fortunately, the field of medicine is moving more and more towards a team-based healthcare model where, surgeons, pain docs, anesthesiologists, nursing, rehab are all working in a collaborative manner. They're putting together protocols to what is the best optimal approach to prehab a patient before surgery, move them through the intraoperative and then perioperative period. And it's gotten better and better and better. Can we still improve it? Yes. But the acute pain service does get involved, particularly, as you alluded, when we put in peripheral nerve catheters or epidural catheters. And this is where we're running that local anesthetic, the numbing medication that stops the nerve impulses to provide pain relief after surgery. And so, yes, we do get deeply, deeply involved in that acute surgical pain space, and then also with internal medicine docs and when patients are admitted into the hospital for whatever cause.
If someone's listening to us and they're going to have elective surgery at some point, like I want to plant a seed in their head for someone who's going to have the knee replacement, the hip replacement, the cholecystectomy, the appy, whatever.
Yeah.
Should they be requesting this of their surgeon? Should they say, hey, I want to be diligent about my recovery. I want to minimize my use of narcotics. Do you mind calling in a pain consult so that I can just have a team of docs who are exclusively thinking about my pain? Because let's be honest, the surgeon, I got enough to worry about. I got to make sure you didn't leak, that anastomosis is fine, that you're not getting a wound infection. Your pain is literally like third or fourth on the list of my concerns for you to have the best outcome.
You are right. And if a patient is listening to this, a person is listening, and they have the ability, they have the wherewithal to go to their doc, their surgeon, and ask, what will pain management be like? Is there an opportunity to interface with an acute pain service, particularly if they're taking opioids now for a chronic pain problem, or even if they're not taking opioids for a chronic pain problem? So we will see them in our clinic before surgery. We will put together a pre-surgical plan for them, which will often include a regional anesthetic approach, meaning those nerve blocks or the catheters. We sometimes involve intravenous ketamine to augment. We will put together the whole plan, communicate with the anesthesiologist, make sure there's a good handoff after surgery, and then we will follow them afterwards. And then we will typically follow them outside the hospital and help the surgeon out with the medication management and the pain management. All of this is not just solely to reduce pain, but to put that person in an optimal state for rehab, for functional recovery.
How ubiquitous is the patient-controlled analgesic device, the PCA that we used to
everywhere?
Okay, so people are still typically getting fentanyl through a PCA in the immediate postoperative phase?
Fentanyl, morphine, Dilaudid, yeah. No, the PCA is a very common tool. And one, it puts pain control in the hands of the patient. Two, studies have been shown that PCA-delivered medication, opioids, they end up taking less than if it's nursing delivered.